Let's go ahead and get started. Good afternoon, everyone. I'm Viet Nguyen. We are here on an afternoon after a nice lunch, so I'm going to try to keep things interesting for you the best I can. Here is the link to a Google Drive that has these slides. And the reason I'd like you normally don't get the slides in advance, although some of the presenters have made them available, is that I don't typically do this tutorial in a lecture format. It's usually hands-on. And so the way I'm going to still do it in a similar way that I normally do it, but the handouts for the slides will walk you through how to create these scenarios when you use the clinFHIR tool. So the thought here is that we have this session, a break, and another session. And over the course of those two sessions, we're going to go over how to use the tool, how to create the clinical scenario, and I'm going to show you how I would build the scenario and the FHIR instances if you had the tool open in front of you. And the reality is, most of the day tomorrow, I'll be up in the clinical track table. And if you want to create some of these resources, I'll be there and I can help you, because that's usually what we do. So a little bit about me. I'm an internist, a pediatrician, clinical informaticist. Been working in interoperability for about 15 years, terminology space, did some work in CDA, and I'm realized how fortunate I am. About 5 or 6 years ago, Graham asked me to get involved in FHIR because they were building out the spec, and they realized that they felt they didn't have enough clinical input into building the specification and getting an understanding, is this fitting the clinical needs of the users? And so at the time I was in industry, and now I'm a consultant. And I also am a volunteer Chief Medical Information Officer or Chief Medical Officer for Health Services Platform Consortium. And it's a group that doesn't create standards, but implements those standards to create reference implementations based on projects. Everything from terminology, they do work with SIMI. We're working with business process modeling to take standards that exist and put them into reference implementation so folks can see how they might work. One of the things that we're going to use in this demo that I would encourage you to take a look at is the HSPC Developer Sandbox. It's developers.hspconsortium.org. And you can sign up as this individual developer. You can get your own sandbox. You can do a turnkey, and it's literally turnkey. And fire up your own FHIR server on it's a happy server on an Amazon Web Services based environment, and you can have both an open endpoint and you can have a secure endpoint. It supports smart and CDS hooks too. So it's a great environment for developing your applications. I'm also involved in HL7's Da Vinci initiative, which is a payer initiative, and so I have two talks on Thursday about that. And in general, I've been helping educate clinicians about FHIR for the past 3 or 4 years. So I always kind of like to level set. I know this is mostly a developers conference, but how many developers do we have here? Okay, so I'm totally honest about I can get down to the stack reasonably well, but if you get down to the code, software code level, you're a little too deep in the stack for me. So I try to help with the clinicians, helping them understand how to work with the clinical data. How many clinicians do we have in here? Awesome. And my hope is, with these, is that you already understand basic FHIR. If you don't, there are lots of great courses around that, because I'm going to use all the FHIR terms, and I'm going to assume you kind of know what I'm talking about. To do the exercises, you'll need your computer, internet access, and a browser. And in general, it works better on Chrome than any of the other browsers. So my hope in these two sessions are you to understand how to think about clinical scenarios, because as a terminologist, one thing I've learned is that we come into every conversation with our own history of what words mean, and clinicians, being one, are some of the worst, because you just take something like clinical guideline, clinical pathway, and we have our ideas of what we think that means. But in the FHIR space, I try to bring us together in this unified idea of what we're using that term in our discussion. Want to help you get a sense of how you can organize a clinical scenario so that you can use clinFHIR effectively, set up clinFHIR use the servers, understand how the servers work for you, and then we're going to do some exercises around looking at data that's already on a server, and then learn how to use and create simple scenarios where you actually create FHIR instances. And one of the big things I love so much about FHIR is that in 5 minutes, if we were sitting down next to each other one-on-one, you could create your first FHIR resource that validates in that 5 minutes. For those of you who've worked in CDA, and I love CDA and it has its great value, it took me like 2 weeks, 3 weeks sitting with those CDA implementation guides to create my first valid CDA. But in FHIR, we do it much faster. And I want to encourage you, as the clinicians in the room, to get involved in FHIR, because we really need that input to say, we create these resources, we think we have, they fit your needs, but give us some situations where we would use it in order to check to see if it really works. And so what we do at the end of the week or during the HL7 working group meetings is get the clinicians together. We use clinFHIR. We do some pre-work in the weeks beforehand to create some of these scenarios, and we try to create FHIR resource instances with the goal that if it works, great. It's another example that we can point to of how you would use a resource. And if it doesn't work, because what we want to model isn't being supported by FHIR, it tells us there's a gap, and we feed that information back to the standards community to help fill that gap. So it's beneficial all around. So let's talk a little bit about scenarios. So a scenario can be really small or really large. And really small could be a simple office visit. It can be a simple exchange of information. Or when we first started Clinicians on FHIR, we created a whole narrative around a patient with diabetes who comes in with an infection, who goes to the ER, gets a whole bunch of labs, gets admitted, and we realized, wow, that's really great, but we can't really attack that in a one-day session because there are so many data elements. There's the factor of time, and so it was very difficult to try to organize the information in a way that we could really try to test FHIR. So my recommendations are to start small. Small in that you have a set of data you want to work with, and you want to try to see, can I represent this data accurately in FHIR? That's a good way to start. And we've done that in the Clinicians on FHIR, and what we're now doing is looking at processes. How do we take that data and go from a medication order to medication administration to the other steps? One example we did in New Orleans is that we took, any pediatricians in the room? No? For those who trained as physicians, when a newborn is born and they're in the hospital, there's a form, a one-page form pediatricians fill out that's really common. Basic vital signs when they were born, their weight, length, whether or not they got hepatitis B, did they get their heels pricked for the screening for newborn diseases, physical exam. And what happens in this form is we collect all this form, the baby's there for 48, 72 hours, and we tear off a copy of the form, separated form, put one in the chart, and we hand one to the parents. And the hope is that that parent takes that to their pediatrician in the first visit. So that's today's interoperability for the newborn record. But what we did in the Clinicians on FHIR session was that we took that form, we broke it down to look at all these fields of the birth weight, the head circumference, and then did what we're going to show you here is did this FHIR gap analysis and some mapping to see how would we take this form and have a FHIR representation of it. Because in my mind, if you can represent that information in that form in a FHIR format, you've now scaled a useful activity and a useful interoperability paradigm to close to 4 million live births a year. That's huge. So we look for kind of use cases like that, at least personally I do. Again, we can look at a point in time or a series of events. I would recommend starting with a point in time. I have an example where we were teaching some students about FHIR, and we took the Framingham risk calculator for cardiovascular risk. And if you look at those data elements, it's blood pressure, it's LDL cholesterol, it's whether or not the patient smokes or has diabetes. And we said, wow, 7 elements. They're all structured, and we were able to represent all of them as FHIR resources. And then we had the patients create that data and then use the smart Python library. For those of you in academics, it's a great library, and had them create a simple application to pull that data, parse it out, and calculate the Framingham risk. So those are really good examples of fairly narrow things you can do to try out your experience with FHIR. The MedCalc, if you ever go to MedCalc or Medscape, has these calculators. It's a great place to start out. One of the things we recognized over time, too, is that the point-in-time scenarios are great, but healthcare is a series of events and a process. And so what we're looking at now and what we're trying to do is the notion of workflow. How does medication ordering and dispensing, how do lab ordering and dispensing, and then ultimately, how do you do things like care plans, which is this kind of Uber workflow that involves many different entities, and the data is really dynamic. And so we have ongoing groups in here. I don't see Dave Carlson, but Dave Carlson's been working with the VA, and it's been several HL7 working group connect-a-thons, and each time they try to advance that dynamic care plan use case. But they really need clinicians there to help the developers in the room understand what the data is and how it's being used by the clinicians. So, so some of the simple things you can do with scenarios, create lists and other things. So how do you plan on to do a clinical scenario? I'm assuming hopefully most of you are starting to work on some projects and you want to get involved in supporting something around FHIR. And so what you do is you kind of have to start with who's sending the information. Is it coming from the EHR? Is it coming from an inpatient or outpatient setting? Who's the receiver? Is it another EHR, another provider? Could it be now we're thinking about registries? We're thinking about public health organizations that are getting information. And for Da Vinci, we're thinking about payers and the value-based care paradigm. So knowing what data you have available to you and who is going to receive it is important. What are the data requirements for your scenario? Is it structured data? We love structured data, vital signs and demographics and labs. But we know that there's still a fair amount of unstructured data, clinical notes, reports. And then there are things that are kind of non-clinical administrative data, such as who's involved in the care, the organizations, and then we're getting into understanding and using the administrative data around things like coverage and eligibility, things like that, and those are being really tested out in FHIR now too. What things do you have that can help you create your scenario? What kind of artifacts? I described that newborn form. It's a nice place to start because we know that that's real world. We know your physicians have to capture that information. So that gives you a sense of how you might ultimately actually have to represent that information as well. Another project we're trying to work on with folks is with the American College of Obstetrics and Gynecology. And for the physicians in the room, there's a form that is started when women come for their first prenatal visit. And that form takes down their basic demographic history, their past pregnancy history, if any, and then over the course of their pregnancy, each time they go see the physician, a certain amount of information is being collected. Their blood pressure, their measurements of the fundus. They might also do tests at certain points. You get an ultrasound, or you get a hepatitis B test, or you get a glucose tolerance test. So that form is now a fairly standardized form that's used across the US to monitor the care of a woman during pregnancy. And it's an interoperability form. It's not only a data interoperability form, it's actually a workflow interoperability form, because if a woman starts her pregnancy at this city and for whatever reason has to move to another city, the ideal situation is that an otherwise healthy person takes that form from the first gynecologist, hands it to the next gynecologist, and all the basic information that the second gynecologist obstetrician has will be what they need to continue the care of the patient. So there's a lot of value, and the American College of Obstetrics and Gynecology is sponsoring some projects around formalizing that representation, because again, if we formalize it and we are able to share that, 4 million live births a year. That's huge. So take whatever forms you have available. It's important to also think about identifiers, whether they be medical record numbers, EMPIs, for payer use cases, subscriber and member IDs. And then you have to think about what are the terminologies you're going to use. And if you're not a kind of a terminology geek like me, you find someone to help you with that terminology. And most of the time in the US, we're thinking about SNOMED codes for condition, LOINC codes for labs, and RX norm codes for medications. So you want to kind of gather all this information in advance before you do your scenario. And then you do what I've been calling your FHIR gap analysis. So you have a set of information. You have a patient, let's say. You break that down to, what do I need to know about the patient? The weight, not the weight, it may be a weight, but like basic demographic information, gender, address, location, things like that. And then you look at what FHIR resources are available in the 100 or so resources we have, and which ones look like they are the appropriate ones to satisfy that need. And one aspect that I'd like to point out for clinicians around FHIR is that I break FHIR resources into 3 big groups. There are these kind of basic core FHIR resources like patient that kind of stand on their own, and they don't do references to other resources. Then you have second level things, let's say medication request that requires a patient, a practitioner reference, maybe a medication reference. So that's a medium level resource. And then you have kind of the uber ones. And care plan is kind of an uber one. There are about 20 plus resources that care plan can reference. And so I recommend starting at the smaller building blocks and working your way up to the more complex resources. But what you want to do is you take your resource and then you look and say, does that resource support have the data elements in it that I need to support in order to fit my data requirements? And sometimes you realize you're going to have to use combinations for like medication. If you're going to do a medication ordering scenario, you want to make sure you can support medication requests. And then also as important is to look at what profiles have already been created. So hopefully most of you know about the US core profiles. It's pretty wide implementation. And so in the Da Vinci project, we want to leverage resources that EHR vendors have already put into production. And so the Argonaut profiles / US core profiles are already in production. And so we know that that's a place where there's already a good amount of expertise. And it also are resources that are more mature. If you look at the FHIR spec, you'll see that the resources have levels of maturity, and patient and condition are like level 5, which means they've been put in production widely. And then you do a gap analysis kind of spreadsheet. And this is an example of one we use for Da Vinci. We looked at patient. We have a bunch of tabs at the bottom. We looked at patient, and we looked at all the elements in patient and their cardinality. And from here, we say, based on our generic need for this data, or the data requirement, does the base profile support everything we need? And we check the box. Yes, yes, yes. No, this is nice, but we don't really need it. But since it's in the profile, we'll just take it as extra. And then we'll say something else they don't have, we may add an extension. So this is really useful because it's already a place somebody already started for you. There's always this tension between using resources or profiles that are already existing and wanting to constrain them down and create new profiles. And it's a healthy tension because you want to constrain to the extent that the sender and receiver are clear about the information that they're sending and receiving. But the more you constrain it down, the less flexibility you have for existing implementers to implement. And so we have to be cognizant about that. And so we're fortunate that the EHR vendors have been fairly supportive. They recognize the limitations of DSTU2 and the Argonauts, but most of them are building off of 3 and planning on R4, which is good for us. And then with this form, the next thing you would do is you want to actually create some resource instances, right? And so what you would do then is use some of these columns on the right to start filling out example patients. So you might write your narrative and say, oh, on this patient it's going to be John Doe, and so I have John Doe. I'm going to make John Doe a white male, non-Hispanic. His birth sex is male. We'll give him a medical record number, and then we'll fill out some of this other form. So this is also the form you would use when you actually go to use the clinFHIR tool to create the actual resource instance. So I'm hoping I don't have to sell you on why it might be helpful to do these resource instances, right? Because then it'll help the developers see some real data to write their applications against. So using clinFHIR is what I call kind of handcrafting resources, and it's really great for you to learn how FHIR works when you're first working with it. But there are other small r resources like MITRE's Cynthia, where they have large volumes of FHIR instances and actually have a machine, the Cynthia machine, I don't know what we call that, the framework, where you can actually create large volumes of patient data based on disease modules. So you can actually create patients, and I would recommend, I'm a big fan of Cynthia. So syntheticmass.mitre.org has their some visualizations they did where they represented Massachusetts, all the counties in Massachusetts, and the population all the way down to gender, similarities in gender and disease prevalence. So it's pretty cool. So here's an example of a scenario. 12-year-old boy presents with pain in the right ear for 3 days, elevated temperature on exam, has a temp of 38, inflamed right ear, no perforations, was given the diagnosis of otitis media, prescribed amoxicillin 250 3 times a day for 7 days, and then followed up 2 days later, has a rash, some breathing difficulties, and on exam has a rash on both arms, but no signs of meningitis, given the diagnosis of penicillin allergy, and then antibiotics were changed to erythromycin. So if you look at this, this is pretty straightforward for a clinician to kind of understand, but how would you break this down into FHIR components? So you would see the 12-year-old boy is a patient resource. Each of these episodes might be an encounter. The pain in the right ear, the itchy skin, the rash, and the otitis media might be conditions. And we won't get into a long discussion around when you use condition and when you use observation, because they're still debatable. The amoxicillin and the erythromycin are medications, and the allergy to the penicillin is an allergy intolerance. So this is a kind of a high-level gap analysis from a simple scenario. Yes?
Quick question.
Sure.
So I understand the concept of scenario understanding here. Is there a corresponding mapping to the HL7 message? Like I'm thinking that in the traditional non-FHIR world, this one will go as like a transcription message, that will go as an ORM message, the initial patient field will go immediately. Is that true, or?
I'm going to say probably, only because I'm not a V2 guy. I didn't start in HL7 till CDA, so I didn't delve deep into version 2. I mean, I think some of these encounter would be, there are probably V2 equivalents to all of these.
I mean, what is the recommendation from you guys? Is it like better to go like this, or to take your current HL7 mappings and start mapping them into FHIR?
That's a good question. Any V2 to FHIR folks in here that might provide a suggestion? The question was, if you could represent this today in V2 messages, do you want to go straight to a mapping towards FHIR? And I answer, if you have the tools to do it, it makes sense.
We've done the mappings, they're on the site. I think
Yeah.
It's possible. There is a separate talk, by the way, on
Graham.
FHIR, and that's not a trivial exercise, because a lot of things where we points out that you distinguish between different resource types, they will all be OBX segments in the version 2 world, so it's pretty difficult sometimes to make it happen.
I think you need the right tooling, and I think the challenge may become in fidelity, given the differences of implementations around V2.
The basis I was asking for, what is the migration path for existing providers? Do they again start all these story creations and scenarios and do the...
I've done mostly new work, so I haven't had the same kind of limitations on V2. So I think it all depends on I guess, the cost benefit for your approach. I know there's large investments already in V2, and the reality is a lot of the integration engine vendors have mappings and methods to do that translation too. So that's something else to consider. But this is just a kind of a visual representation of those resources we just talked about. You could have a procedure that has a diagnostic report, and it's through these are references. And so for a clinician, it's useful to understand visually in your mind, build that mental model of how the data fits together, because it's not truly kind of hierarchical. It's kind of a network of data, which you'll see in a second. So this is a representation of how the data is kind of linked, and you can put these in, as the text strings as well as the coded fields in the FHIR resource. So download the slides, and you'll be able to follow along mostly. These slides that I created were a little while back, and so the examples aren't exactly like you would do on your own, but they're pretty similar. So this is the clinFHIR main page, and this is where I want to give a huge plug for David Hay. He's the one who actually normally teaches this tutorial and has been in Amsterdam, and he's out in New Zealand and wasn't able to be here, so I'm pinch hitting for him. But he created this, it's a FHIR client, and it has a set of modules, and on the left, and we'll go through the modules, and it has, we'll do a little tour of this you can see. So you can create a user, and so with the way I did the slides, it just looks like this, so you know kind of where to click. So you don't have to follow the verbal narrative. So these are the modules. The first one we use is a patient viewer. It's a simple FHIR client where you can connect to the FHIR server, and you can search for a patient by name and identifiers, and then pull them into the client so you can visualize the data. You have a server query, so you can select a server, and you can, it has a little tool to help you write a query. So if you want to write a query against a code or an ID, it'll show you what that query would look like. We're going to talk about Scenario Builder, which is where we actually build the scenario. He has some functionality for a logical modeler that I'm going to show tomorrow in a clinicians profiling for clinicians discussion. And the others are still relatively new, but some things around looking at value sets and building value sets. So this on the right is where you select your servers. And I'll have a description on how you do the servers, but here you click Edit, and you have a drop-down. He has some basic servers already listed. It supports both version 2 and version 3. But you'll have to select a data, a conformance, and a terminology server. And one of the great features, and I don't show it in the slide deck, but you can actually, if you have your own FHIR server, and it's an open endpoint, and you know the URL, you could put that into the add server function and check whether or not it does terminology and conformance, and then it'll run a test. And if it passes the test, you can add that server to your list. So that will help you as you're creating resources for your own purposes. Just some links to the FHIR documentation and some videos. So David's blog is phirblog.com, and he does lots of great posts on FHIR in general and clinFHIR specifically. And then this terminology browsing. If you don't already have a set of bookmarks, it's useful to know where you want to look at your terminology. So in your when you do this on your own, you want to create your a login. So it's an unsecured website, so don't reuse any of your passwords, and don't put any HIPAA private information on there. So with respect to the server roles, a good number of you probably already understand this, but I'll just do it for completeness, is that you'll have one server that will be used to store all the patient data. That same server or another server can be used to check conformance around profiles of your instances. And then you'll have a terminology server, because not all servers do terminology. Graham's server does, Happy does, and HSPC's does. But that's where you want to, if you're going to do a SNOMED lookup, you need a server that's going to serve up SNOMED codes or LOIN codes, and so that's why you need that. And by identifying that clinFHIR in the background knows where to look for this data. And you want to make sure that you're consistent, that you're always using the same version of FHIR. So here, as you work through the example, you'll select a server. I'm actually going to recommend folks use the HSPC care plan server for this one because there's a really good patients. So let me show you that. So I'm going to select a patient. Here it's Bob Anyman, but he's not here yet. But in your example, you're going to look at the server and find a patient named Betsy that has a ton of really good resources. But once you've selected the patient, you'll get to this screen, and this is the patient viewer screen. And there are two parts that you want to use. The other ones have some functionality but aren't as built out yet. But this first tab is the Resource Explorer. And with the Resource Explorer, you have a list of all the resource types that are available for that patient and how many instances of that resource are in. Let me use my pointer. And so if you select one of them, like this condition, you now have a list of all the instances of that condition resource. And then when you click on a given instance, you get a view of that data. So you can look at, it defaults to this tree view, but you can look at the text view, the JSON view, the XML view, or the references view. And what you have on the top here is a list of versions. By default, when you do a query on a resource and you retrieve it, you'll get the most recent version. But we know that data kind of evolves, and FHIR keeps track of those through the version history. And so you can click on one of the numbers and get the previous versions of that resource. And then on the right-hand side are the inward and outward references. Is anyone here uncomfortable with the notion of inward and outward references? Because I've had in other discussions. But really briefly, it's the idea that this resource points to a whole bunch of resources. So they're outgoing resources. And then the resources that are inward are resources that have this particular condition in its definition or in its structure. And I was trying to explain that to folks, but it didn't quite make sense. So I'm glad you guys understand it. But so you can click on either the outward, the inward reference and change the focus and be able to see what the data is. And it's really helpful as you're trying to explore and understand the structure. Yes, sir.
So right now, the scenario that you earlier had in the slide, that's not shown yet.
That's not shown here. No.
Okay. So this is exploring existing data on the server.
Yes. And in your example, I confirmed. So I asked you to set your server to care plan, and gave you a couple of different identifiers, and you would just copy that and paste it into the ID search and click search or load, and it'll load into the screen. But it's similar because this is another care plan patient. Okay, so I've already building this out, and I didn't need to. Okay, so I really love this. This is an example of one of the benefits of FHIR. This is the resource reference graph. One Sunday afternoon, I was looking at some website, and there's this cool kind of graph. I wonder if David can put this into clinFHIR. So I sent him a quick Skype message in New Zealand. He said, I'll look into it. And like 24 hours later, he found a library and created this. So when you pull up this patient, you'll see this graph. The patient, it assumes that all the resources, each of these boxes is a resource. And the screen assumes that all these resources pertain to this patient. And the graph will show all the inward and outward references to each of those resources. And so what you can do is you can click and scroll and zoom and see how these resources interact with one another. And I think for clinicians, especially those who don't have a kind of tech background, it can be a little challenging to think about how these resources relate to one another. And when you see this, it makes sense. You'll see that this care plan has a bunch of conditions and observations and practitioners related to it. And then when you click on any of these, you can see what the resource looks like in either the tree view, text view, or JSON view. So this is really cool. So just zoom in, move it around. So we did that. So in the exercise, you'll go in, you'll load up this patient, CC Pat Betsy in the patient ID and do a search. You'll find her, click her, and load, or you can do Anderson. Or on some of the really large servers, like the Happy server, you can change the server. You can find other patients. One thing that's really important is everything starts with that main page. So if you change the server names, just close your other tabs and restart the modules so that it knows to look in the right place based on the new servers you identified. But I recommend, as part of the exercise, explore the data to see what it looks like. So how are we doing? I'm way ahead of myself. Oh, I have 5 minutes, right? Oh, I'm not way ahead of myself. Great. I'm going to pause here because this next set kind of goes together, and it goes to the second half of the discussion. So I'm going to pause here and take some questions, if you have any questions. Yes, sir.
Is there, with the workflows you're creating here, is there a way to tie that into the actual clinician's workflow as they're going through their EHR?
So that's a really good question. So when we first started doing clinicians on FHIR, the question is, how do you tie this to what they would see in the EHR? Yeah, the clinician workflow. And how does this relate to the clinician's workflow? And we addressed this at the first Connectathon, clinicians on FHIR session. We had a 7-page narrative that we wanted to represent, which was altogether too big. And they tried to create a EHR-like view of the data. The challenge was it didn't have terminology binding. It didn't have a whole bunch of things that the clinicians, because they were being offered an EHR view, expected EHR-level functionality. So the short answer to your question is, it's purposely like this because we didn't want clinicians to think they were using an EHR. We want them to get to the point where they feel like they're working closer to the developer and the data layer and not the user interface layer. Because the user interface layer, there's a lot of expectations that people have. Like, oh, I punched in DM. Why didn't it give me diabetes? You know, it's those kind of things that when we set the stage for this tool, it doesn't give them the expectation of the EHR, and we don't have EHR workflows in there. So you almost have to think like the EHR as you're using this tool. Like how would a order dialogue look? And what things would I put in an order dialogue? And then how would I represent the data that comes out of that order dialogue as a FHIR resource? So that's kind of the short answer. Thank you. Question?
When you did the patient search,
Mm-hmm.
is there like MPI screen behind the scene or just a plain file you have? If no MPI, then how would this particular case you want to relate to the MPI?
How would you relate to the eMPI on the search?
Yeah, masturbation index.
Sure. So if you had modeled in your system, and let's say you had your own FHIR server and you had a bunch of patient data instances, non-PHI even, and you put in the identifier, you put that eMPI, you could search using this tool. But well, to a FHIR server, but not necessarily to an eMPI. You're like, oh, like a database of eMPIs and then do a secondary search? No. Other question? Was there another question?
So as a clinician, when you look at the lab report, most of the examples in the FHIR has been at the order test level and not at the complete report.
Mm-hmm.
So how would you prefer to show that the FHIR diagnostic report response? Would you like
For
to see it at the complete report level, or is it at the individual order section?
I would say it would be up to you and how you frame your clinical scenario. So if you were to take, so it would be very relatively straightforward if you did a CBC and you just do the simple 4-component CBC. You could do each of those observations, the white blood cell, the platelets and whites and such. Each of those could be an observation, right? Observation resource, and then you would put it into either have multiple components, or you could put it into a diagnostic report. It all depends on how you would want to try to model it, and because both is a legitimate FHIR way to do it.
In some reports we have the CBC, a thyroid, and maybe a cumulative,
Mm-hmm.
which is a complete history
Okay.
observation.
Mm-hmm.
So when you want to translate that into a FHIR, what would be a best option to show?
I would probably look at representing each of those observations as individual operations, and then looking at the application layer, how you would package those into a presentation of a report. So it might be, because you might order a whole bunch of things, but when you deliver the data to the end user, you might select one or more of those observations to display. And there's a really great area. If anybody doing genomics, there's some really good efforts around trying to represent genomic data in FHIR. Yes, sir.
Just one question. Do you know whether there's any publicly available mapping between clinical data and FHIR resources? Like, let's say we want a certain piece of information.
I think the answer is SIMI. You're going to say SIMI? So there's a whole effort. So the question is around a mapping of clinical data to FHIR. And so we have high-level resources like observation. And what we know is it works well for lab, really well for lab. But we want to document clinical observations. Let's say your reflexes or a rash or something like that. There's a group within HL7 called CIMI, the Clinical Information Modeling Initiative, that's trying to take those commonly used clinical observations and building a standard profile for each of these. So with the idea, it's at a clinical layer. If you look in LOINC, there are about 250 loin codes for systolic blood pressure. That's because they care about whether or not you do it in the left arm or you get it by a radial artery line or some other methods. But at the clinical level, the clinicians need to know systolic and diastolic. And if they want to dig into how it was done, they'll dig into how it was done. And so CIMI is looking at that. What is the clinical level of abstraction so that if you're going to query an EHR and I say, I want all the blood pressures, and actually the US Core, the Argonaut profiles has blood pressure, you get it always back the same way. So then the importance of that is you can aggregate better. So you lose something when you abstract, but you gain something in the ability to aggregate and to display data kind of consistently. So, all right, they told us very distinctly that we're supposed to stay on time. So we'll do how long is this break? It's like half an hour? Okay, so we'll be back in half an hour. If you get a chance and the network looks better, download the things, and then we're going to walk through creating some instances.